get through. Go. Hi.
How many are with you guys?
Five.
Right here. There's no one else but us.
We didn't have anybody else.
Yeah, we're just
Okay.
love to join us.
Okay, Grandpa's gonna sit here. And your mom, Grandma will sit there, and Grandpa, I'm gonna sit right here. I'm gonna sit where it's facing around. Okay? Yeah. Oh, on the other side, on the back side?
Yeah, we're staying with our stepmoms. You guys just try to get to I'm fine. Oh, that's nice.
Southwest, right? Yeah.
He's hypo, but
We got a lot of information yesterday.
one of the doctors here.
That's nice. When I get stuff, no, good one.
They just,
I don't think so.
he talked about
The group over here, Stonebridge, they're doing
Yeah, on the other side. Over there where Jeff got the,
and then they
with your walker. Are you gonna sit with your
talked
walker?
for a little bit, but they did.
Oh, no.
They were just that's really
Oh,
all.
we're from Ohio.
They're gonna do it again today for a while, and then tomorrow.
we just people, we just passed them.
Newer?
No, I put it in the It's a responsibility for a pointer.
Sorry?
Pointer.
No, I don't. Well, you can use the mouse for that
Okay.
because it's on television screens.
Yeah. So I have to use the mouse. Okay?
Yeah.
Oh, Netherlands.
Yeah,
Speaking
yeah.
computer. Yeah,
So this one?
this one.
It will be in there.
Let's have a try whether it works or not. Okay.
Yeah, it works.
Yeah, okay, and
You can go page up, page down for the different pages and use the mouse to point out. Oh, that works as well.
where's the mouse?
Oh, there.
here.
Yeah.
Okay. But I need something to. I yesterday. Okay. And here escape or.
pass it over if you had seen him. That's why I'm asking. Okay, no problem. So.
Okay.
All right, thanks.
So, welcome everybody. How many? I see that everyone's quite energetic this morning. We didn't hit the buffet as hard as we might have. That's okay. There's a lot of new folks in the audience. So just in terms of gauging what information should be repeated, raise your hand if you weren't here yesterday. That's like a bunch of people. Okay. There's going to be a lot of repetition with the talks today. Yesterday, we had most of the folks kind of stand up and share their journey and story or what they felt was relevant with periodic paralysis. I encourage anyone who has kind of a pearl to share that, through the course of the question and answers, because we all learn from. In case people get in trouble. So, if you're going down, maybe have your partner go with you to, over there, and we can sort it out. And Shelley will be milling around. And bathrooms are, I guess, out, and there's a restaurant like. If the temperature is too high or too low, let Shelley know because that's a problem for some folks.
Doesn't matter. Okay.
This is it.
Yeah.
Yeah.
I'll make it large. Okay. So, thank you very much for the kind invitation. It's a pleasure and a special honor for me to speak here as an invited speaker. In the field of periodic paralysis, I'm a student of Frank Lehmann-Horn, and I think you know the definition of an invited speaker. He is somebody that comes from a long distance, speaks with an accent, and tells you something you already know. And I will qualify as an invited speaker. So my topic today is to give the sodium channel, the muscular sodium channel, the workhorse of muscular excitations, and mutations of the sodium channel that cause either hypo-PP or hyper-PP. And then we have here the calcium channel, essential for coupling of excitation and contraction, and all the mutations there cause hypo-PP. And we have here the chloride channels. When they are mutated, you get a myotonia. So we have four major types of muscular ion channels. The sodium channels that govern membrane excitability, calcium channels that couple the membrane excitation to muscle contraction, the chloride channels that stabilize the resting membrane potential, and the potassium channels responsible for membrane repolarization. And this here on the right, that's the basic structure of a channel with its different conditions. And you see here we have the central pore, the alpha pore, where the ion flux goes through. You all know in periodic paralysis, the main feature is paralysis, weakness. But we also have, as a feature of these disorders, the sensitivity to potassium, and sometimes we have stiffness. Stiffness means, in that sense, myotonia. And if you see here, and these features overlap a little bit, and if you see here weakness as a feature, you can say if there is weakness and it's caused by a kind of muscle channelopathy, the cause has to be either a problem with the calcium channel or with the sodium channel. The same holds true for potassium sensitivity. If this is the case, the problem should be either in a calcium channel or in a sodium channel. If you have stiffness, I mean myotonia, stiffness, channel is good for. They govern the membrane potential. There's a gating of the channels. I mean, whether they open or not, that means gating. And usually they are voltage gated. Ion fluxes and have a change in the membrane potential of the cells. But you might have other stimuli. You might have shifts in pH, electrolyte concentrations that trigger the gating of the channels and lead to a change in membrane potential. The other important thing one has to know is that we have a different contribution of the electrolytes inside and outside the cell. We all know that extracellular, I'm looking for the mouse, where is my mouse? We have a high concentration of sodium and a low concentration inside the cell. And with potassium it's vice versa, high concentration inside, low outside. This gives you the same thing, and otherwise, inside the cell, high potassium, low sodium, outside, low potassium, high sodium. And this concentration is maintained by a membrane pump. The basis of all, the basis of excitability is the action potential here. And in order for an action potential to be generated, you need a membrane that is polarized. And this polarized membrane doesn't come for free. The cell has to pay something for that. The cell needs energy, and the energy uses the membrane pump, the sodium-potassium pump. That costs the cell energy, and this resting membrane potential is governed by the potassium concentration in and outside the cell. And the first thing that was discovered in periodic paralysis, especially in hypo-PP, was that in case of weakness, we have a paradoxical depolarization of the muscle membrane that is weak. And this is not what has been expected, because those famous equations here, Goldman and Nernst equations, they did predict the contrary. So the initial explanation was that this paradoxical depolarization was explained by something, misfunction of the membrane pump. If you look closer on these things, you see here, this is a histogram of different membrane potentials of different muscle fibers. And you see the largest proportion of muscle fibers, P1, is polarized. But even on normal concentration of potassium outside the cell, you have a small amount of muscle fibers that are depolarized. We call them P2. And these P2 muscle fibers do not develop as much force as the P1 muscle fibers. And that's the main thing. That's the cause for weakness. And even in a healthy muscle fiber, if you decrease the sodium, the potassium concentration outside of the cell, the amount of the fibers in the P2 state that cannot develop force increases. So we have a bistable membrane with P1 and P2 potentials and fibers. This is what you here say C is a so-called H-infinity curve, a basic curve to understand channel function. And if you look here, these are the fibers at the P2 state, and at the P2 state you have almost 100% of all sodium channels available. That is, they can make excitation and they can provide force. But if you have a muscle fiber in the P2 state here, you have only 20% of the sodium channels available. That is, you have only 20% of the force, so to say. At P2, most sodium channels are inactivated, and that means we cannot generate action potentials. So the fiber switches between these P1 and P2 states. Inactivation of sodium channels, which you find here, this means no action potential. This is the cause for the weakness. This means no brain excitability, and this means no activity in the EMG if you're able to do an EMG just during an attack. If you make an EMG during an attack, you only see very, very few muscle motor unit action potentials because they come from those P1 muscle fibers that are not weak. You have a closer look on the relationship between P1 and P2. You see here in green, even in a healthy muscle fiber, that the P2 amount proportion increases if you lower the potassium concentration outside the cell. The lower the potassium, the higher the P2 proportion, the more weakness. This is one thing. If you have another problem, an additional sodium leak inside for the cell, this means a higher increase, a higher proportion of sodium inside the cell. The proportion of the P2 fibers increases even more. So the proportion of P2 fibers is governed by the external concentration of potassium and by an additional amount of sodium inside the cell. Where does this come from? And this is the point where the mutations come into play. This is a sketch of a so-called sodium channel. And if you see here, for hypo-PP, most of the mutations are in a special segment, a special part of this channel. And these mutations cause some very special, very new thing. They cause an omega pore inside the channel, an additional pore in addition to the alpha pore, which is the main pore of the channel. And this additional omega pore is the cause of an additional current, a leak current, that is activated usually by hyperpolarization. And this additional current depolarizes and destabilizes the resting membrane potential and thus increases the fraction of the P2 fibers. And this current is independent from the ion-selective alpha pore. So one single amino acid in a special position of the segment can cause this leak current, and this is the cause why the fraction of the P2 fibers increases. And it depends on the particular type of the mutation, whether this leak current is induced by hyperpolarization or by depolarization. And the kind of mutation there always governs also, or might govern, the different reaction to oral potassium administrations. This gating current is very small, about 1% of the alpha current that elicits the action potential. And this might be the reason why it has been so discovered only recently. Usually, and that's an open question, it's a sodium current, sodium ions influx there, but it could be possible that also protons go inside the cell. And if this would be the case, that's a possibility, I don't know whether it's true, that could be an explanation why attacks preferentially occur during the recovery period following muscle exercise, because there we have an external acidifidation in the external outside the cell, and the protons are very small cations, and they should be able to pass through this leak pore. In hypo-PP, for example, the mutations are nearly always point mutations that neutralize that arginine segment, and these voltage sensor mutations of the arginine, they cause about 90% of hypo-PP cases. And so only mutation in one single amino acid determines whether you have this disease or whether not. Last word to biostability. Here you see this graph. Here we have the extracellular potassium concentration, and that's in right, these are the normal fibers. If you lower the potassium concentrations, you come to the turning point of P1, and then the membrane bistable jumps to P2, where we have a depolarized fiber that cannot develop force. And even if you have an omega current, this happens earlier. That's the main thing. And in the presence of the omega pore, that's the blue line, the membrane instability occurs at a mild potassium reduction. And the smaller the omega current, the more severe hypokalemia is needed for the shift to P2. Okay? So that was all on bistable membrane potentials, and we have this additional sodium influx inside the cell, and this sodium takes water with it, and this causes, by and large, and here in lifetime, a vacuolar myopathy, and this vacuolar myopathy is, so we think, responsible for the later onset fixed myopathy, especially in the quadriceps muscles, that patients with hypo-PP usually can develop. So that's the idea. We have here, during the attack, an intracellular sodium accumulation and an edema causing reversible weakness, can be triggered, can be counteracted by medication, and by the years, during lifetime, this sodium accumulation inside the cells can lead to fibrosis and fatty replacement, and so it's a cause for irreversible weakness. Here you see a normal MRI of a normal muscle, and within the years you see here the muscle fibers are replaced by edema and by fat, and here in the old days, here it still has only a very few amount of healthy muscle fibers. So the idea is, if you have a severe mutation, that means a large leak, a large omega current. This leads to a high intramuscular resting sodium with reversible permanent weakness, and going on irreversible weakness with fatty muscle replacement. You have less ictal sodium increase and a mild ictal hyperkalemia. On the other hand, you might have a mild mutation with a small leak, with a lower intramuscular resting sodium, but a larger increase of sodium during the attack. And in the attack, you have fiber swelling, compartment syndrome, leading to vacuolar myopathy. In this case, you have a larger ictal hyperkalemia. Two different sides of the same coin. This is about something about MS, so I don't want to be misunderstood. MS is not a channelopathy in the narrow sense of the word, but you see here, even in MS, an intracellular sodium accumulation is associated with disability and a progressive course. The only point I want to make at this point is that an intracellular sodium accumulation inside the cell is not good for cell function. So you find this principle: too much sodium inside the cell is detrimental for cell function. You do not only find in muscular diseases, but also in other nervous diseases. So in MS, for example, you find higher total sodium concentrations in lesions and also in normal appearing white matter. But I don't want to be misunderstood. MS is not a channelopathy. Just the higher increase of sodium inside the cell is the same, and that's detrimental for cell function. Okay, that was all about physiology. Now we come back to phenomenology, to the real things. You know, we have in periodic paralysis, we have episodic weakness, not necessarily periodic, but episodic. Periodicity would mean at regular intervals, and you all know the intervals might be irregular. We know that the bulbar and the muscles for respirations are not often affected. We have it usually in the morning after wake up, and we have particular triggers that are very important. During the attack, the attendant reflexes are depressed. You can have a later onset myopathy, which I explained by the sodium intake inside the cell, and the paralysis is not necessarily flaccid. The neurologists always expect that the muscular weakness should be flaccid, but here, to the influx of sodium and water, it might be the case that the weakness is that the muscle is not flaccid during the weakness. That might be not the case, not regular the case. This is just a summary of hypo-PP. At this point, we have these mutations I've pointed out, and just nice to know, hypo-PP you find only, there's a model in an animal for that. You find it in Burmese cats. It's a disorder not confined to man. We all know that not all patients with this phenotype have the same genotype. I mean, not all patients with a phenotype of an episodic weakness have one of the already known mutations. And maybe 1/3 or even less proportion of the patients may have a new mutations. For example, that are mutations of the gene that govern the sodium, the channel, the membrane pump, or other mutations that have something to do with cell metabolism, downstream the effect on electrophysiology. And these mutations here, they are, where's my mouse? These mutations here, they are reported in single individuals. That might be the cause for the disease of patients not with channelopathies in the narrow sense of the word. And these two possibilities here have been reported by the group of Michael Hanna, then thus you should invite him next year in Dublin. Now, something more familiar for you, what evidence does suggest periodic paralysis? Of course, if you have a family history of episodic weakness, the potassium should be normal between the spells. Usually it's in the lower normal range. You should have a sensitivity to potassium, muscle cramps, muscle pain is frequent, and you might acquire the permanent weakness, progressive with age, and you have the typical triggers. Mutation, of course, is a final proof, but not all the patients with a phenotype have this clear-cut genotype with mutations in either the calcium or the sodium channels. In hypo-PP, the attacks are usually longer than in hyper-PP, and in hyper-PP you have myotonia, which you usually do not have in hypo-PP. The triggers. Yesterday we did talk extensively about triggers. Triggers are extremely important. You have stress as a trigger, very unspecific, but stress releases adrenaline that causes hypokalemia. Infections and vaccinations release inflammation factors. Surgery is pure stress, and you might get sodium infusions and glucose infusions. Ambient cold environment is a well-known stress. Hormones like adrenaline are stressors. Rest after work, rest after exercise is a very well-known trigger, might have to do with the protons awakening from sleeps, and we have yesterday talked about that carb food, high, rich on carbs is a very good trigger. Sodium salts, of course, are also very good triggers. This has nothing to do with the sodium inside the cell. The sodium here, if you eat chips or other sodium-rich food, mean that you get a hypernatremia, outside the cell, and this causes diuresis, and diuresis causes potassium wasting. So avoiding salt is maybe as good as medication. Cortisol and other drugs are triggers too. it's very important that you, as a patient, that you are able to recognize your own triggers and are able to describe them. For the diagnosis, for the doctor, I think it's extremely important. If you come to a doctor with an episodic weakness, of course the doctor does not know that you have periodic paralysis. He has to figure it out against narcolepsy, against seizure disorders, and so on. And therefore, please, if you are able to provide the triggers, though, that the doctor can characterize your phenotype. That's very important. The other thing is, the triggers are important for management, of course. If you know your own triggers, you can avoid them. And avoidance of the trigger, that is trivial, but it's rather important. And if you can avoid the trigger, that's a half of the therapy. And yesterday, we talked about misdiagnosis of a conversion disorder. This happens frequently because, especially in the beginning, because, as you know, if you see a patient with hypo-PP, with periodic paralysis, between the spells, he is absolutely normal. You don't see anything. And in the spell, if the sodium is already normal anymore, you have depressed reflexes, and that's it. And stress as a trigger, that can cause everything. Every condition worsens with stress, even headaches or so. But if you can tell the physician, well, I know these spells, and I know if I have a carbohydrate meal, they can come. This should not lead to a mix-up, to a conversion disorder. This should point out to an organic problem. So triggers are for the doctor and for you and for the characterization of the phenotype extremely important. So you should know your own triggers and which are the worst one for you. How can you prevent weakness spells? That's pretty clear. Serum potassium should be as high as possible. Low sodium food, low carb food. Keep moving. Continuous mild exercise. Hold your muscles warm. A little bit physical therapy. Avoid stress. That's the adrenaline and the equivalent medication. What medication do we have? You all know that we have potassium in the acute stage, and if in the chronic we need the carboanhydrase inhibitors, Diamox, Keveyis, and the aldosterone antagonists, the potassium-sparing diuretics, and the beta blockers. If weakness is permanent, or if you have many attacks, many spells, you need a consistent and continuous ingestion. How does potassium work? The main mechanism of all these drugs is that they shift P1 to P2, that they increase the potential of the proportion of the muscle fibers which are normal polarized potential. Thus, they increase strength. Yeah? Of course, you all know the disadvantages, the side effects of potassium ingestion, stomach pain, something like that, and that potassium competes with other substances for intestinal absorption. So the aim should be to raise your potassium by reduced excretion. Do not take potassium wasting. Aldosterone antagonists behave in the same way. They raise potassium and they shift P2 fibers to P1. And the preferred substance nowadays is eplerenone, Inspra. I'm looking for my mouse. Where is Inspra here? That's the substance I use most often. You know that it's difficult in hypo-PP to raise potassium even between the spells. Usually it's in the normal lower range, and patients often have the fear that they could overdose potassium. That's not possible if you have a healthy kidney. Only in the case of kidney insufficiency, additional potassium intake might be dangerous. Potassium-sparing diuretics, they increase serum potassium by reduced excursion, and when we have that shift from P2 to P1. And carbohydrate amylase inhibitors work in the same way. Diamox shifts P2 fibers to P1, increasing strength. And we have been known for a long time that Kivey's diclofenac is more potent than Diamox is. But as a pity, I don't have too much experience with diclofenac because Kivey's is not yet licensed in the European Union. But it's actually an old substance, and as it was used before, and we know that it is a very effective drug. Side effects, especially paresthesias, sometimes nausea and dizziness in the beginning, especially in Diamox. Beta blockers are underused in hypo-PP. In my perception, they take away the stress, and so I usually use them. They have a lot of side effects, but usually you can tolerate them. In certain kind of patients, they are very effective because they take away the stress. If you need a long-term medication, we usually combine two medications of different groups at low dose, let's say an aldosterone antagonist plus Diamox, and try to keep additional potassium as low as possible to minimize the side effects. That's the way we are doing that. Hypo-PP might be modified by sexual hormones, which they have their own effects on potassium and on the membrane excitability, premenstrual symptoms, for example. And there are certain drugs that worsen hypo-PP, especially drugs that reduce neuromuscular transmission and drugs that cause hypokalemia, of course. Drugs causing muscle ischemia, also statin, are not recommended. They might cause a little bit of myotonia, but they are tolerable in many patients. The individual prognosis is governed by the type of mutation. I have already mentioned the two ends of the spectrum, severe hypokalemia or no hypokalemia but progressive weakness, the genetic background, and environmental factors, of course. Lifelong, strong physical work favors development of permanent weakness. Now a few words on hyper-PP. Hyper-PP is just the opposite. Here the channels close too slowly and ions continue to leak inside the muscle cells, and this leads to a oversensitivity and stiffness in the muscle that we call myotonia. And during the episode of muscle weakness or paralysis, the potassium ions are released from the muscle, and that's the vicious circle in hyper-PP. That's the problem here on the left side in hypo-PP, and in hyper-PP we don't have the mutation here. We have the problem that hypokalemia induces a slight depolarization, that open channels that are not able to inactivate. Usually the inward sodium current stops here, and in hyper-PP you have a persistent inward sodium channel because the channels cannot inactivate, and so you have this vicious circle here. Depolarization leads to sodium channel opening, and this persistent sodium channel opening leads on the one hand to myotonia, muscle stiffness, because you have still an inward sodium current, and on the other hand they lead to paralysis because the channels cannot, because there are not enough channels even available anymore. It's dominant, inherited. You have attacks, generalized muscle weakness. You have the ictal increase in serum potassium. You have also progressive myopathy, and you might have EMG myotonia. The attacks are frequent and they are shorter than in hypo-PP, and the factors that trigger it are potassium-rich food, fasting, and ambient cooling, of course, and stress triggers everything. Acute attacks do not require treatment. Some patients can abort attacks with sugar, mild exercise, with a carb intake, and the usual medication is stimulation of the sodium-potassium pump. And on the long hand, you need thiazide diuretics that lower the potassium and the carbohydrate inhibitors. Well, this concludes my presentation. You know, you have the picture of the zebras. We have, as physicians, we have the saying: if you hear hoof traps in Central Park, it should be horses. But here, hoof traps, they can come from other things. You are the zebras, and you are the rare cases. And zebras, of course, I have been told, each zebra has its own pattern of stripes, and that's exactly your case. You might have your own mutation that you do not, your mutation and that your effect you do not share with another person. That makes you so, let's say, unique. This concludes the presentation. Thank you for your attention.
Genetic variations that could
Well, I just wanted to make the point that some of the phenotypes of periodic paralysis cannot be explained by the kind of channel mutations we know by now. So we have the same phenotype as let's say, mutation of the membrane pump, or with a mutation concerning the energy metabolism of the cell. So it might be the case, and we know that from two single cases, that the same phenotype of paralysis can be caused not by a mutation in a channel, but by a mutation otherwise inside the muscle. That's what I wanted to say.
As you went through the medications, different potential medications and how they may or may not affect those channels. And my question was on other types of medications that have been used, for example, lamotrigine with seizures. Lamotrigine, yeah. So, any evidence on that?
Lamotrigine as a sodium channel antagonist usually used if you in muscle disorders in myotonia. And it works against myotonia.
But it is. As far as affecting these channels, is it a similar mechanism? As far as opening or changing those?
As a sodium channel antagonist.
Okay.
Yeah, and it works against epilepsy and in muscles against myotonia. Yeah.
You were explaining about.
No.
You were explaining
Still not.
about sodium going into
the cell.
Yeah, the cell, and about that explains how severe maybe your case is.
Yeah.
Can you quickly re-explain that, because I kind of missed that, and that to me is interesting.
Can you explain that with them? I didn't get.
Can you explain exactly? You said intake of sodium and water into the cell over a long period of time.
Yeah. By this additional pore that's caused by the mutation, and if you have so many attacks over a lifetime, you simply increase your proportion of sodium inside the cell, and that's not good for cell function. Sodium should be outside the cell.
What are the symptoms of that? I think you.
It depends on the cell. As they saw in brain cells, they stop function, and in the muscle cell, they let's say stop working, but they fail to contract. And the symptom is the cell is not able to provide its function anymore, whatever its function is, and the muscle cell has contraction.
One of the slides for hypo.
Yeah.
We can't hear.
One of the slides for hypos, there was something about vitamin B12 that I didn't quite catch. What's the relevance?
that this has to do something with the ingestion of potassium. Vitamin B12 might influence the ingestion of all the potassium.
Does it, in a good way?
No, not in a good way.
Not in a good way. Oh, okay, interesting.
I have the permanent muscle weakness, and my daughter's starting to get it, and I have a grandson. Is there any way that we can sort of ward that off? And you also mentioned carbonic inhibitors and aldosterone. We are on a basis, and doctors don't know of any combinations.
Courses should be helpful against that.
Yes.
I personally have not so much experience with that because it is not licensed in the European Union, and I should take a known inspra in addition. I should use in that case. Because the thing is that the aim is to remove the sodium outside of the cell.
They would be good together.
Yeah. Yeah.
Okay, I'll tell him.
Dr. Weber, if I may ask a couple of questions. The cold as a trigger, do we know the physiology? Is that cell membrane threshold? Or?
It's well known that especially sodium channel mutations are temperature sensitive, and I really don't know. But if there is other disorder, paramyotonia congenita, which is extremely cold sensitive, and patients with that kind of mutation they develop even after transpiration, and then if they lose if they're sweating and the wind comes, and this amount of temperature changes may be sufficient to cause weakness. But the cause of it I don't know. Maybe Dr. Cannon might comment on that. Why the temperature sensitivity is caused.
Yeah. So the short answer is we don't precisely know, but the idea is that many of the sodium channel mutations that lead to myotonia is because that inactivation is too slow. That's what was shown on one of those graphs. It turns off too slowly. If you cool things down, all these events occur more slowly, even normal channel activity. And so the idea is there's a threshold amount of slowing that will tip the balance and cause myotonia. And if you're already slow to begin with because you have a mutation, then as things get slower and slower as you cool them, the mutant channels are going to get you in trouble more quickly than a wild type channel was. And that, in computer simulations, is one reason why there might be temperature sensitive.
So alternatively, would there be benefit from something like a sauna on a regular basis, or infrared heat, or?
I'm not aware, I'll let Dr. Weber answer, but I'm not aware that heat per se is necessarily beneficial, as opposed to the fact that cold is clearly problematic.
Is that right? Okay.
Yeah.
Okay, and then barometric pressure, is that something?
Barometric pressure?
Is that something that's been noticed? In my body, I can feel when the weather is changing, when there's rain coming.
Yeah, I think we're all like that.
I'm just curious.
I would say that's an indirect effect. A direct effect of barometric pressure, I don't think very important.
And sorry, the last question.
Be good to ask him and see what there's that.
Dr. Weber, as far as monitoring CPK, is that something that's been studied to look at?
CPK, in the progress of disease, CPK is just a sign of an unspecific sign of muscle damage. And in the beginning, CPK is usually normal or very mildly elevated, and in the later stages of the disease, it's normal too, because the muscle fibers can be destroyed, but in between they can be elevated. So CPK as a rule should be as normal as possible. Mild elevations can be tolerated.
Just as a raise of hands, because that seemed to strike a chord. The barometric pressure thing, like who does that? Yeah, so yeah, a lot of so that's one of those things that maybe isn't as we probably should be studying a little bit.
Sugar is used to treat acute hyperkalemic attacks, and I'm wondering if there's a place for it in regular maintenance, the way that Diamox is used, or is it just used for treatment of acute attacks?
Well, the acute attacks.
So no, there's no need to have a maintenance, like to eat sugar regularly.
Usually not. But if you usually the patients I know they feel like an aura of the attack. They feel a discomfort in the muscle and something like that, and then if they then intake sugar, it usually is helpful and might prevent the attack. But not a necessary regular intake. Not necessary.
I was just curious, we were talking about muscle damage, permanent muscle damage,
Yeah.
and that kind of thing. I don't know about anybody else in the room, but I've been told I have fibromyalgia because from head to toe, I have nothing but muscle knots and ridges all throughout my arms and legs and everywhere. And I'm wondering, is that what you talk about when you talk about muscle damage, or is that completely different?
Fibromyalgia is something different. Fibromyalgia is an ill-defined condition, and it is muscle pain. And muscle pain, of course, belongs to discal paralysis. I mean, if you have muscle pain, you do not have an additional, there's no need for additional diagnosis of fibromyalgia. Fibromyalgia is most often diagnosed by rheumatologists that do not know the discal periodic paralysis. And I think if you have I mean with permanent muscle damage, I mean muscle damage in the narrow sense of the word. And if you do a muscle MRI, for example, in the type of muscles that are most affected in your case, and this muscle MRI is normal, and you have full strength, you have no permanent muscle damage.
Oh, okay. Thank you very much.
Hi, a quick question from the caregiver's side. Oftentimes, a doctor will see an attack and says, "Oh, she's got a stroke," because a lot of the items that they count as a stroke are evident. So the question I have is, how can I convince a doctor that what he's seeing is not a stroke, or what kind of differences between a stroke and an attack are there?
Stroke is, of course, the strokes are much more prevalent than episodic weakness in case of paralysis. So doctors are trained in thinking of stroke, and you have to, in stroke, you need very fast treatment. That's the reason why they are thinking of stroke first. And usually, because of age, the patients with paralysis are used to be younger than the stroke patient, and they have relapsing attacks. I mean, it's not a single attack. Without relapsing attack, the stroke is usually a single episode. You may have relapsing stroke at older age, but you have relapsing strokes are very, very rare. And in the acute attack, a stroke is usually some asymmetric thing. I mean, half hemiparesis, only the left or the right side of the body is paralytic and not the other side. And another different thing, in muscle disorders, you have only muscle symptoms, I mean weakness. In stroke, you can have a lot of additional symptoms because stroke is a brain disease. You can have sensory symptoms, you have speech symptoms, you can have headache, and so on. And these symptoms are not prevalent, like let's say speech disturbances, you don't have in a muscle disorder.
I will say, just in specific to Anne's case, when she has an attack, sometimes it's half the body, and it really could look like a stroke. And
absolutely.
The problem is, I think that the physician has to think, what's the thing that's going to kill the patient?
Yeah.
That, so they have to rule out stroke before they go on to something less.
I mentioned that. And the special problem is on family hemiplegic migraine. Young woman with a hemiplegic migraine and headache, that's very difficult to distinguish from the stroke.
Jacob, would an electrical pulse clear that? What a lot of people don't understand is when we're paralyzed, you cannot make our muscle work.
Yeah.
If you hit it with
that's
right, if you hit it with an electrode, it will not jump.
Yeah.
Now with a stroke patient, I assume it would still jump.
Yeah.
So I don't know. That's just a good question. If my wife were taking me in and they said, well, I think he's having a stroke, she could say, well, give him a shot, electricity, and you'll see that he's not in a stroke.
I don't think I like that. It hurt.
Awesome.
You can feel it.
You graduated medical school.
Oh my gosh.
Honorary
We've all been hurt.
Question for the experts. How high? I'm just curious what each of your opinions are. How high for a single dose of oral potassium or in a 24-hour period? I don't know, Frank.
Whatever's needed, I think. Whatever you.
I mean, so let's just do numbers. 100, fine, right? Can I hear 200?
200. 200. Let's go to 200.
So let's say someone's paralyzed and in an hour's time they swallow 100. That's fine, right? Okay. So what about like 200 in an hour? In that hour?
It's needed and tolerated, why not?
Okay, so they take 200 and they are, maybe they're coming out of it, maybe they're not, another 100? Or is at what point do you say, like, you shouldn't go above this number? I'm just curious. For me personally, not to be selfish about it, but like, it used to be 60 was fine for me. And in my really severe attacks, I'm fine. I need like, probably up to 180, 200. And then when you talk to folks, many people in past conferences and this conferences have done, amounts that just sounded so crazy. I mean, Shelly, where's Shelly at? Oh, she's outside. Anyway, she takes like 14, 20 milliequivalent of pills during the day. It's just a lot. That's a lot of potassium. I'm just curious, at what point does it make you feel uncomfortable?
I mentioned this. As long as the kidneys are healthy, you can't overdose oral potassium.
Okay. I mean, I think that's something that the average physician probably is uncomfortable with. I don't know how many people have encountered physicians who are kind of not into high, and I think a lot of people get underdosed because of that. Maybe that and strong bridge, we can, I think potassium dosing guys over there, I mean, if you want to talk about education to physicians, putting that in the slide deck would be really important in terms of being helpful. And pharmacists. Oh gosh, yeah. And Samantha will address that, I guess, later.
My mother's first episode, that was 5 years before she started having full-time episodes, was because she was on HCTZ, which flushed all your potassium, and then they gave her like 60 or 80, something like that, potassium daily. And then they decided that they needed to get her off the HCTZ, so they put her on spironolactone, but they didn't change the potassium. And the potassium spiked to like 6 or 7 or something crazy. They said she was nearly dead. And she was paralyzed, so they started flushing her. And they said you can only take so much potassium before it kills you. So that's why when he was asking how much potassium is too much, because when she went in, her levels were so high that all the doctors were freaking out because.
Well, of course, you have to check the potassium level in the serum and others run.
Where's the safe level before you give yourself a heart attack or kill yourself?
Usually in the attack you have a low potassium, of course. And if you have aldosterone, you raise the potassium level. That's the main thing of this drug. And therefore you have, of course, to reduce the additional oral potassium. and keep them both in balance.
Jeff, you have break. Yeah, so we'll take a break, and then Shelley has like public service.
Well, hold on. Okay, I just want to explain the temperature in the room. Why I've been on my phone. They finally came up so that I could try to figure out what was happening. We have different thermostats in these different rooms. They open up. This is actually several different conference rooms. So it's not working properly. We have blankets, we have more coming. They're gonna set this side at 72, that side will be set at 75. But there's a difference with the air conditioner. So they're all on 72, but it's not working correctly. So this is the plan. So let me know how you're feeling. If you like to be warmer, it's over here. It is actually colder over there. So
yeah, 75
we
on
might
that
have to
side.
go up from 72.
But it's warmer over there, even though it's set at 72.
Even though
And
it's
that set at
colder,
75, it's colder
actually
over there. You know.
So we're just trying to make it more exciting because y'all are just and I am watching people to see if anyone needs assistance. We have a lot of people that weren't here yesterday. We have the blankets on the floors and the pillows. We want everyone to be comfortable. If you see someone who needs help, please flag me down. I'm running a circuit along the back wall. So just please, because we just want to help. But we're breaking now. The bathrooms are, again, over here. You go out the door, turn to your right. If you go to the stairway, you're going the wrong way.
Thank you for all your information. It's a lot to take in. I'm going to watch that video over like 3 or 4 times. I know. I'm so glad.
In about 15 minutes.
Yeah, I mean, it's hypothetical. It's plausible. But
There's other things that he's understanding, trying to break it down.
I can look this up.
I think he's doing an okay job. And the thing is that almost all of us. So, yeah. I'm See, and I couldn't practice. I'm familiar with this chart, so I've been looking at it. I'm trying to create
Oh, sorry.
That to the graph of there. Okay, so that's as big of a deal as this type. Well, not quite. He didn't lose us just by throwing that up there. I'm going
Are you cold too?
I'm almost, and that's the thing is too. I kept choking. I didn't eat calcium yesterday, and my throat kept spasming, and I would do an hour and a half. So I'm just Anne has not Shelly this since in 20 years.
Always do. I can't
Since she
stand
went to
Shelly, what do you think?
Okay.
Feel better too.
Yeah. And she was a new service and she was a guy that
Oh, yeah. No, she's just a good friend. But he's like that stubborn teenager. He's not a teenager.
She goes down for a couple days.
I think he's probably
She still has
No, keep it. That's what they're there for. No, they have to warm up. So
do our best. But like, there's a lot more coping than I didn't have. Like I every night when I have dinner, I get my pain jumps up to like a 70. And I get really heavy. Chest was heavy, everything was heavy. And all I want to do is lay down. I just I go lay down for about half an hour. And I get up and I still have. But why don't I take something or I guess the answer would be to get a small dose to manage it.
Gotta lay it down now.
It's great. Like I'm taking out everything. The normal, like 600 calories. It's not over the top, but my body is handling it. This started up again in the last 4 months. Basically, it's because I started working full time. My stress level is higher, and it's over my level of homeostasis. So my stress is too high right now. I'm trying to manage it, but and so little things like eating
carbonic acid, whatever they're selling
So, and I think about that, and I'm like,
that's why hormone conversion. But if you're not drinking enough water, bananas, potatoes, or you can't just water, it's not as much, just don't eat
why? I don't understand.
So it's gonna bump the diet.
Oh. Can I ask you, what is your potassium level when you're doing
Oh, that seems like that might be good for me to try. I don't know about coaching though. Like if it's like we don't not really having to be she's not having paralysis and she's managing it through. But because she is so prone to like she's showing signs of POTS, orthostatic hypertension, and palpitations.
Or she's already there. Does some of those potassium sparing things have side effects?
It's likely to make her heart It's not necessarily like a full panic attack, but that's how it's going to run. It was before she tried out for undermovement. Her heart was like, I put my hand on her heart, and she was just like it was bouncing out of her chest, and she wasn't like, if there was any other symptom of like chest, she wasn't like in a panic attack. She just had the symptom of this bounding heart. It was just like, yeah, and so yes, so it's like she's not. That's how her body, and so Nate's like, she's got to learn how to manage stress, and I'm like, well, yes, and I'm like, absolutely we need to work on stress management. But at the same time, don't blame her. Don't like accuse her of being some weak-minded or it's not her. Yes. She's not like a high stress, like she's pretty chill. And the doctor, when I brought her into the pediatrician, that's maybe something, and he was one of the ladies, he just said he gave her a depression screening right then and there. He just had her go and do a designation for him. And she's like, oh, you're fine. And I'm like, you know, yay! Very short. She gets those. She's been getting short acting is the key word that sells right here. That's how quick it works. It's not like a build up or a
taken on a regular basis.
I mean, I would be able to tell within a week because, like, honestly, it's every meal I'm having this reaction. Not every meal, just the dinner meals. And I think it's the building up at the end of the day. Like, by the end of the day, my body's already physically exhausted. And that just tips over. And I have my doctor because he doesn't know.
I'm glad I'm not the only one.
I have a he's been really, and well, first of all, I don't have a doctor. Like because he's just lose weight.
But that takes months. Let your arteries go through some damage.
That's 6 months. And
that's
in our
6 months of damage to your arteries. I don't. You're at 145?
It was 148 last night.
That's too high.
Well, and that's not even the problem. It's the bottom. It's my bottom is the layer. The bottom is high. It's that's sometimes it's even over 100.
So think of it like this: systolic top number is that's pressure. It's related to pressure.